Dr. Glick is here today to kind of talk to us a little bit about pharmacogenetics and what it is, why we need to be doing it, why your doctor should be looking at it. And so I'm just going to throw it out there to Dr. Glick. Welcome, first of all.
Thank you.
And what is pharmacogenetics? What is, and we call it PGX. A lot of people hear that out in the marketplace. What exactly is that?
Pharmacogenetics is testing patients' genetic types to find out how they metabolize certain drugs.
Is this something that is new, it's been around for a while, or is something that you practice constantly?
I've heard about it for years, but in a more practical way, it's only been around in the last year or two. It's a very powerful tool to use with your patients to try to help understand how they're using their medications, whether or not they are getting side effects or not, or whether the medications are being dosed optimally.
Okay, so you have someone come into your office that may not be really responding well to a certain medication
all the time.
And so walking me through that, I mean, what do you hear from your patients a lot of times that that makes you say, aha, that's something that I should check out further?
Well, so whenever the therapy isn't being maximally resulted, the patient's not getting the results they're looking for, the symptoms are still there, we're still addressing it. This happens all the time. So doing this kind of testing can really get to the bottom of where the problem is and how we can adjust the medications.
Okay. Is it a pretty easy test, or
very simple test,
kind of walk us through a little bit of
so
how that works?
The patients come in and they get a mouth swab. There's 2 swabs that we swab the inside of their cheek, and from that, those samples are sent back, and 3 to 5 business days later, they get the results. So about a week later, we go over the results, and then from there, we can kind of adjust the medications. I find that, previously in medicine, we would just guess at what medications we should be using. And I mean, when I think back to my training, I go, well, I mean, what else did I have?
Right.
So I treat 100 people with drug X, and 25 of them have some problem. I just either assume they were the problem or don't like medicines or something like that. And I knew that there was some sort of liver enzyme problem with it, but I didn't know the details or what to do about it. And so this has really elucidated the vast majority of the problems. And so now when I'm dealing with not just mainstream things, which this helps with as well, but really complicated problems for people on multiple medications, you're able to really get in there and dial in like a laser and say, this is probably the guy that's the problem. Let's switch over to this class and see if that reduces our heart rate problem or our urinary issue or whatever it is.
Does it affect really how much you give of a certain medication, or is that?
Absolutely. And in my experience, you have to always take the patient's symptoms and adjust it. So I've seen people that have had pharmacogenetic reports that were abnormal, but the medication was working and their symptoms were fine, and we didn't have other side effects, maybe like a low heart rate or some other thing that would be concerning. And so we just leave it alone. But other times, they're on a drug, they're depressed, it seems to be working, at least we all agree it is, then we get the testing and find out, oh my gosh, it's not even working. So then we increase the drug, and this last 10 years of just this kind of depression on this med is resolved. I mean, this is laser-like focus in terms of medications, how we can treat people. I mean, there's no more guessing.
Right. So very powerful from a standpoint of being able to give the patient exactly what they need versus having this kind of shotgun effect, prescribe and cross your fingers type of a situation.
And I was trained in this way, and this is not a knock to any physicians that are out there. This is the way we were trained to practice, but technology has advanced to a point where we can actually now start to do the things in a very tailored, individualized, personalized way for each individual patient. I mean, it's an easier way to practice.
You see this as something as becoming really almost like doing blood tests.
It's a necessity. It doesn't make any sense not to just do it on all of my patients.
90% of your patients get this test.
The only reason I don't have it on somebody is because they travel a lot and we've missed them or something like that. But yeah, no, everybody will have it done in the practice.
How many people would you say you actually, after you get the test back, have to make an adjustment to their medications?
60%, easy. Yeah.
So there's that 40% that you look at it and you go, this...
Right, for now though, this is based off of their current medications, their current problems, and we say, well, we're doing fine, or it doesn't apply. But that doesn't mean that they're not going to be in a car accident and need narcotics for a month or two, and then now we've got a problem. Or that doesn't mean that they're not going to develop AFib or get a DVT, and now we're going to have to develop another issue. So you know, the value for my patients not only is obviously picking the right meds, making the right adjustments, reducing the number of meds is if necessary, but is having this information going forward for other events that they might occur.
What I'm hearing you say,
lifelong.
right? So you only have to do one test. Once you get the results, then medications may change as they get older, or as you mentioned, an accident, something like that. You don't have to worry about changing that.
Yeah, and I just tell my patients, give me a call if any of these things happen. We'll get this information to your doctor in the emergency room in the hospital. And of course, the report's easy to read, so they just take a look at it, look at the categories. Because again, we can't expect all the physicians to be able to read the stuff, even though the report is very easy to read. At the time that you're dealing with some of these issues, like in an emergency room, those doctors are not up to this speed, but they're moving way faster than I would move in a practice. So understanding that and knowing that the report has to be simple, they've got to make a change, and it can make a huge difference. It's some powerful stuff. So we just get that information to them, the patient or the doctor, and I always make myself available to get on the phone for the doctor to answer any questions.
What other areas do you see in medicine that it really does apply? I mean, you talk to your clinic and some of the things there, but what are some other areas in medicine you see that are very, very useful?
Well, definitely the psych stuff. I mean, antidepressants. I mean, patients are on antidepressants.
Which, how many people are on antidepressants nowadays?
I mean, I don't know. Test the water. It's in there, right?
Yeah, exactly.
But, antidepressants, people get on these drugs for the right reason, but never seem to get off of them. And why is that? And it's likely because it's possibly the wrong diagnosis, or nobody has tried to take them off and see what the side effects are and how they're metabolizing the drug. So psychologic stuff is definitely a big issue. The cardiac stuff is definitely a big issue. I mean, many patients are on multiple drugs for rate control, especially like atrial fibrillation, things like that. If these drugs aren't being metabolized, I mean, you might end up with a pacemaker.
So we watch TV at night, right? And we see all these great drugs, and I'm for Big Pharma producing some really great drugs for us that really, really do help people. But it's always interesting to me to watch how many side effects they have and what they have to post, which they legally, legally have to do that. But if you're having that issue just taking one drug, then certainly there's got to be some concerns about I'm taking this one and now I'm taking something else. How are they working together? Are they working against each other? Are we actually harming ourselves by taking those? And speak to that a little bit.
Anytime there's more medications and things that need to be detoxified by the liver, that's going to be a problem. But, the reports I've seen have come across actually with mixed results sometimes too. So one drug needs to be increased and another one needs to be decreased. And so again, the difference of those two is where their problem or their symptom arises. So, sometimes it's really simple. They have pain, they're on a narcotic, they have a lot of pain and it's not working. We switch over to another one, problem solved. But sometimes when you're dealing with cardiac issues with multiple different classes, calcium channel blockers, you're dealing with beta blockers, you're dealing with different things, where they interact causes all kinds of side effects.
So you see this as the future as far as how medications, it's almost, I use this term of, as physician, having a moral and ethical obligation, as an insurance carrier having a moral and ethical obligation to make sure that patients are getting the best in outcome.
Absolutely.
You see that really as going forward as really, why would not you do it? I mean, why would you do it another way, correct?
Well, yeah, I mean, I can't unlearn this, right? And so since I know that it's out there, I mean, I treat my patients the way I want my family members treated. I know what I was trained with. I know how my brain thinks in terms of figuring out what choices are next in terms of medications, and I know what this says. So it's like, sometimes now, the only problem I see with the test is it makes me feel like I want to rely on it, and I'll jump to, well, let's get your test, and then I'll see what the results, I'll make a decision. It's like, well, for years I've been making decisions without this test, but this test is going to improve the ability for me to make those decisions quicker and more precise. So
right. And it's all about patient outcome. It's all about taking care of the patient and really getting them to respond and have a quality of life really that they would expect. So
yeah, many times we're treating a lot of problems, and then that medication causes us to treat another problem and down the line. And I, even last week I had another patient that literally came in and said, I've stopped all of my medicines. He's got rheumatoid arthritis, high blood pressure, high cholesterol. I mean, 10 different major drugs that he should have been on, stopped them all and was feeling great. And his blood pressure was a little high, 160 systolic. Wow. So I mean,
right.
I don't know. I mean, I've seen people go into the hospital, with 20 drugs and be discharged with 2. Everything seems to be okay. Mm-hmm. So, it's interesting sometimes how patients can go without a lot of drugs and how they respond to that. Sometimes the body is just kind of compensating for all these changes.
Right. Very interesting. Well, thank you so much, Dr. Glick. I appreciate you stopping by, and hopefully y'all learned something today. He was very informative from a standpoint of really what pharmacogenetic testing is all about, how it can help you, why your doctor should be looking into it, and many of them are, or if they're not, we can certainly help them become more educated through Aspirio Labs. Thank you.
Aspirio, uncovering the unknown.